I'm Dr. Michael Reardon, one of the cardiac surgeons at the Houston Methodist Hospital. I want to welcome you to this week's Grand Rounds. I want to remind everybody that you can text in your questions by texting DeBakey to 37607, DeBakey to 37607, and we'll answer your questions as this goes on. It is my distinct pleasure this morning to introduce one of my very good friends, Dr. Nicolo Piazza from McGill in Montreal. Nico was born in Montreal, grew up in Montreal, did medical school in cardiology in Montreal, and then he went over to Erasmus in Rotterdam and spent 5 years doing his PhD with Professor Patrick Sorois in transcatheter valve therapy. Then went on to Munich and spent some time with Professor Rutgard Lange, and we're fortunate that we got Nico back across the Atlantic. He's back at McGill, where he's the co-director of the transcatheter valve and structural heart program. Now, I've known Nico for a long time. In fact, when I started TAVR, I turned to Nico's writings to learn how to do TAVR. And Nico's contributions to the field have been legion and legend. But where he's really made the biggest contribution is imaging. Every time I think about imaging, I turn to Nico to learn about how to do the right kind of imaging. And this field is completely driven by imaging. So I'm really looking forward today to hearing from my good friend Nico about the eyes, the imaging as the eyes for the heart team. So Nico, thank you for joining us today from Montreal. We look forward to your talk.
Thank you, Michael. Good morning. Michael, just to confirm, do you see my slides?
We see your slides. Looks good.
Okay, thank you. Okay, so here we go. So today's objectives are really to realize how cardiac chamber views can be used as a common imaging language within the heart team. We'll realize that these chamber views can actually be seen across various imaging modalities. Secondly, we're going to try to understand the relationship between these chamber views and what we call optimal projection curves. These curves help us to understand when planar structures such as the mitral valve and the aortic valve are in plane and how that relates to chamber views. And finally, we'll go over some clinical case examples and see how these chamber views and S-curves can be used in everyday clinical practice. Now, just a little bit of music trivia. There's a relationship between the Beatles and Dr. Hounsfield. We all know that the Beatles were extremely successful back in the 60s, and they signed a record deal with EMI Records, and with EMI Records. And what happened was that with the success of the Beatles, EMI was able to provide a research grant to Dr. Hounsfield. And so Dr. Hounsfield, with that research grant, was able to develop the first CT scanner. In fact, it was called the EMI scanner. And so the first experimental CT scan was conducted on a mouse in 1967. Imagine it took almost 8 hours to scan a mouse. And the subsequent use of a CT scanner for human clinical practice occurred in 1971. So nearly 50 years ago, we performed the first clinical CT scan of the human brain. And you can see there the middle picture, Dr. Hounsfield, standing right next to what is known as the EMI scanner, where the imaging portal was just big enough to insert the patient's head. And in fact, that first patient that was scanned, they found a tumor in the left frontal lobe. Sorry, in the right frontal lobe. So this is a common situation in the cath lab, where you have the interventionalists and the echocardiographer trying to communicate what they're both seeing. And so what we'll try to do today is to create what we call a modality-independent terminology. As opposed to the interventionalist saying I'm working in an REO-caudal view or LEO-cranial view, and the echocardiographer saying I'd like to see a parasternal short axis view, or an apical four-chamber view. we're going to see how both the interventionalist and the echocardiographer and other members of the heart team can talk using chamber view terminology. So what you see here is a cylinder, and you know how this shape appears is really a matter of perspective. Depending on which side you're standing on, you may appreciate a square or a circle. And similarly, how the heart appears is only a matter of viewing angle and not of imaging modality. What you have here on the left-hand side is a three-chamber view of a heart specimen. But that same three-chamber view and the same relative position of structures can be appreciated on echocardiography, on fluoroscopy, on CT and MRI. So all of these images that you see here on the screen have a three-chamber view of the heart. So the way we're going to understand multimodality imaging is we're going to try to relate how chamber views and S-curves can be put together and sort of try to understand how different structures in the heart can be appreciated with respect to chamber views and S-curves. So let's start off with chamber views. What you have here are the commonly recognized echocardiography chamber views. You have a one-chamber or a short axis view of the heart on the top left. You have a two-chamber view on the top right. You have a three-chamber view at the bottom left, and you have a four-chamber view at the bottom right. And so we see these in everyday clinical practice. Now, this is a rotational angiogram of the heart with a pigtail catheter sitting within the left atrium. Now this picture, or this rotational angiogram, is being taken with the C-arm rotating from LAO90 all the way to RAO90. Now if we would stop this rotational angiogram at three potential points, we'd appreciate that maybe perhaps we're starting to see chamber views. So what you notice here is a one-chamber view where the pigtail is in the left atrium, and right below you have a spherical or a circular left ventricle, or a short axis view of the ventricle. In the middle, we see that we have the two-chamber view, or the bicommissural view, with the left atrial appendage on the right-hand side of the figure. And finally, on the complete right-hand side, you can make out a three-chamber view. So what this is telling us is that there's chamber views within our cath lab during fluoroscopy. Now, this is a CT scan of the heart, and on the right-hand side, we have changed, let's say, the colors of the CT scan in order to generate a fluoroscopic simulation. And so this is a three-chamber view of the heart in an RAO caudal view. You can see the numbers at the bottom of the image. It says RAO 54, caudal 29. And we'll see what happens as we rotate around the C-arm. So we'll start in an RAO caudal view, three-chamber view. We move to an LAO caudal view, which gives us a short axis view of the heart, or a one-chamber view. If we move from LAO caudal to LAO cranial, you can appreciate a four-chamber view of the heart. And if you come to a shallow RAO cranial view, you'll finally get a two-chamber view of the heart. And so the formula in the cath lab for chamber views is such that you have the one-chamber view in LAO caudal, you have a three-chamber view in RAO caudal, you have a four-chamber view in LAO cranial, and you have a two-chamber view in a shallow RAO cranial. Now that two-chamber view RAO cranial, let's say RAO 30 cranial 10 or 15, is your typical LV-gram that you appreciate during everyday coronary angiography. Now, these chamber views that you see here, The 1, 2, 3, and 4 chamber views on fluoroscopy are the exact chamber views you see on echocardiography. And so the goal is to somehow match what the echocardiographer and what the interventionalist is seeing on their respective screens. Now, we spoke about the left heart. We can also do this for the right heart, and you can use this information for transcatheter procedures involving the right heart. Here, again, we're starting an REO-caudal view, and you can see the numbers there, REO 39, caudal 35, written in small. And in this case, the REO-caudal view actually starts with a 2-chamber view of the right heart. Now, if you go from a 2-chamber view, REO-caudal, and you go to an LEO-caudal view, you get, again, the 1-chamber view or the short axis view of the right heart. In LEO-cranial, again, we get the 4-chamber view of the right heart. And interestingly, the 3-chamber view of the right heart, or the RVO, right ventricular outflow tract view, is seen in an REO-cranial view. And so the formula for the right heart is that you get a 1-chamber view in LEO-caudal, a 4-chamber view in LEO-cranial. That's similar to the left heart, as you can imagine. Where it changes is the 2- and 3-chamber view. For the right heart, the 3-chamber view is an REO-cranial. For the left heart, the 3-chamber view is an REO-caudal. The 2-chamber view of the right heart, as you see here, is an REO-caudal. And the 2-chamber view of the left heart, as we've seen previously, is an REO-cranial. Now, what this allows us to do is move towards pattern recognition in structural heart disease. And so what you see here on the complete left-hand side is a 2-chamber view of the heart. And we've highlighted the mitral valve annulus in turquoise, the aortic annulus in yellow, and the atrial septum in green. And so just to give you an example, in the 2-chamber view, you always have an overlap of your aortic and mitral valve. Whereas in a 3-chamber view, the aortic and mitral valve are completely separated. Now, this may seem like a trivial point, but imagine if you're doing a transapical procedure and wanting to get your 035 guide wire or catheters across the mitral valve. You know, those of us who've done this numerous times can attest that sometimes it can be a humbling experience. And despite wanting to get into the mitral valve, you always end up into the aortic root and ascending aorta. Now, a quick trick is just to go into a 3-chamber view, REO-caudal view of the heart. And therefore, you can separate the aortic from mitral valve and drive your guide wires towards the inferior and left side of the screen. Now, we say that we're moving towards pattern recognition in structural heart disease because we haven't had time to develop that pattern recognition. Although we've developed pattern recognition for coronary angiography. Now, with coronary CT scans, it's possible that we'll be moving away from pattern recognition for percutaneous core interventions. What you see here is a 3-chamber view, 4-chamber view, and 1-chamber view of the heart on fluoroscopy with superimposed coronary arteries. So just to give you an example, this is a 1-chamber view or LEO-caudal view of the heart, and we know on echocardiography the walls would be anterior, posterior, septal, and lateral. And what we appreciate is that the red circumflex artery is wrapping around the mitral valve, and that the OMs, the obtuse marginals, are supplying the posterolateral wall, as you see there, and the LAD, which is heading towards the anterior label and giving off diagonals. You can see that the diagonal is supplying the anterolateral wall. And what you see on fluoroscopy there And what we simulated from a CT scan and what you see on echocardiography are in fact a one-chamber view of the heart, or a short axis view of the heart. And so we can also do this for the four-chamber view. This is an aleocranial view of the coronary arteries. And so on echocardiography, we understand that you have a septal and lateral wall designation on the four-chamber view. And you can see here clearly that the LAD, which separates the left ventricle from the right ventricle, gives off septals, which is supplying the septal wall. And you can also appreciate here that the obtuse marginals are literally going towards the lateral wall of the heart. So again, we are trying to correlate what we see on fluoroscopy to what we see on echocardiography. So that was the little bit on chamber views. Let's move over to S-curves, and then we'll try to put these two together. So an S-curve may seem complicated at first, but is a rather simple concept. What you need to imagine is that the S-curve provides you an RAO or LAO with a corresponding cranial caudal angulation where a particular structure is in plane. And so you can see there the rings of Saturn. Imagine you are wrapping around the rings of Saturn and always seeing them in plane. If somehow you can map those coordinates onto a RAO, LAO cranial caudal grid, you generate what we call an S-curve. And so every point on that S-curve have the structure in plane. Just to give you an idea of this, you can see at the bottom left-hand side, you have a yellow S-curve. And this is a typical S-curve of an aortic valve. And so if we drive across the S-curve, we will always see the aortic annulus in plane. Okay, and we typically use one of these views to implant a transcatheter aortic valve. Now, an S-curve can be generated for really any planar structure in the heart. It can be done for the aortic valve, the mitral valve, the left atrial appendage orifice, the atrial septum, the tricuspid valve, the inferior vena cava, the SVC. All of these planes can generate an S-curve. And so there is a general S-curve for the aortic annulus, for the mitral, for the left atrial appendage, and atrial septum. What we're saying is that there's, again, a pattern recognition that we can develop also for S-curves. And so after analyzing 100 of patients' S-curves, in those with mitral regurgitation, those with aortic stenosis, those with normal hearts, those with tricuspid regurg, you can see that there's some very little difference between S-curves of those with mitral regurg and aortic stenosis of the aortic annulus, mitral annulus, left atrial appendage, and atrial septum. So this allows us to create some generalizations. So for instance, let's take the mitral annulus, which is the second figure there, or the second image. You can appreciate that its S-curve can be appreciated in an LAO cranial quadrant, RAO cranial quadrant, and RAO caudal quadrant. Those are the quadrants that the S-curve intersects. That means that we can see the mitral valve in plane in any of these quadrants. Now, the other interesting fact about the S-curves is that the quadrant, the three quadrants it does not touch, the one quadrant it does not touch, you can appreciate that structure en face. And so the mitral valve annulus can be appreciated in the short axis view in the LAO caudal quadrant. Again, the quadrant where the S-curve does not intersect is where you can appreciate that structure en face. And so two structures which have similar planes, for instance, the mitral valve in turquoise and the tricuspid valve in yellow, will have similar looking S-curves as you see on the left-hand side. Now, the other interesting fact about S-curves is that it can also give you an understanding of how this planar structure is behaving in the body. And so what we have here are 3 S-curves of the aortic annulus of 3 different patients. And not to get into too much detail, but when you have a vertical S-curve, as you see there on the complete right in patient 3, you have what we call a vertical annulus. When you have a more horizontal S-curve, you end up with a horizontal annulus. And so one of the best ways to appreciate whether a structure is vertical or horizontal in the body is to have a look at its S-curve. So now let's bridge the gap between S-curves and chamber views and see how these two concepts behave together. Now, what you have here is the mitral valve highlighted in purple, and we start with the mitral valve in plane in a 3-chamber view. Now, as we're driving along its S-curve, we can somehow appreciate that the mitral valve can be seen in plane in various chamber views. So we'll play that again. So we start with the 3-chamber view, mitral valve in plane, 2-chamber view, mitral valve in plane, 4-chamber view, mitral valve in plane, and then we go back to a 3-chamber view mirror image with the mitral valve in plane. And so if we look at the mitral valve from this perspective, where on the bottom right you have a 1-chamber or short axis view of the mitral valve, you have now here the 2-chamber view that can be obtained by cutting the mitral valve from commissure to commissure, the 3-chamber view that can be appreciated cutting the mitral valve from its anterior to posterior direction, 4-chamber view cutting the mitral valve from approximately P1 to its right fibrous trigone. And so these chamber views that we see on echocardiography can be appreciated on CT and also can be appreciated on fluoroscopy. And these chamber views are somewhere found on the S-curves of the structure of interest. And so what you see in the light blue circle in the LAO-caudal quadrant is the mitral valve en face. And as you run along the S-curve, where you intersect the red halo, the yellow halo, and the green halo, you end up in some particular chamber view of the heart with that structure in plane, in this case the mitral valve. We can also do this for the tricuspid valve. This is the S-curve of the tricuspid valve. And so what you have is a 2-chamber view of the right heart in an ariocaudal. As you drive up the S-curve, you end up in a 3-chamber view, or RVO, right ventricular outflow tract view in areocranial. As you move along into the AP cranial or LAO cranial, you get a 4-chamber view of the right heart. And again, the en face view of the tricuspid valve is seen in LAO-caudal. And so what we've done is now we've spoken about chamber views, we've spoken about S-curves, we've seen how these two concepts can be connected. What I'd just like to do in the next few minutes is talk about the atrial septum and chamber views and S-curves and see how that can help us understand our transseptal punctures. And so what you have here is the S-curve of the atrial septum. the atrial septum can be seen en face in a areocaudal view and in plane in the remaining quadrants. And again, depending on the pathology, if you have a normal or a left atrial enlargement or right atrial enlargement, you can appreciate whether or not your atrial septum is vertical or horizontal in the body, and that might affect how you approach a transseptal puncture. Now, these two views are commonly known to those performing or involved with transseptal punctures. We use the bicaval view and the short axis view of the heart. And so what you see in this cartoon is in fact a two-chamber view of the heart with the atrial septum en face. Whenever you see this typical picture in textbooks with the atrial septum en face, you are looking at a two-chamber view of the right heart. And here the green line is showing us how we obtain a bicaval cut, and the blue line, which transects the aortic valve there in short axis, this is the trajectory of the short axis view when we perform these procedures. Now, one thing we didn't share were two additional chamber views. We spoke about the 1, 2, 3, and 4 chamber view. But echocardiography also has a short axis view of the heart and that bicaval view. And we can generate those similar views as you see there on CT scan. And so below the echocardiographic images, you have the corresponding CT images. And now if we obtain those CT images, we can translate their fluoroscopic viewing angles. And let's see where these views, the short axis view and the bicaval view, which by the way have the atrial septum in plane, okay, which tells us that these views will be found on the S-curve of the atrial septum. And so these two views, the short axis view and the bicaval view, or really it's a lateral view, can be found in the extremes of our fluoroscopic quadrants. And of course, we're not going to work in those views, but just so that you understand that these two views on echocardiography are also found somewhere in our X-ray beams. Now, what's important when performing transseptal punctures is that you understand how your target structure looks like. And so here we are performing, for instance, let's say a transcatheter mitral valve intervention through the septum. And so in a bicaval view, what we maybe don't appreciate on echocardiography is that the mitral valve is seen en face. And what you can see here is the mitral valve en face in turquoise. And you have orange dots, red dots, and yellow dots. Those dots represent the segments of the mitral valve. The orange dots represent the A3, P3. The red dots represent A2, P2, and the yellow dots represent A1, P1. And so if you perform what we call an inferior puncture, that is a puncture closer to the IVC, you can imagine that you'll be closer to the medial commissure, or you'll be closer to the A3, P3 segments. If you move to a superior puncture that is closer to the SVC, that's why we call it a superior puncture, we will be moving away from the medial commissure and towards the lateral commissure. And so really what the bicaval puncture gives us is hovering over the mitral valve. it allows us to hover across the various segments of the mitral valve. It does not provide us any information about the height above the mitral valve, and we'll see that in the short axis view in the next slides. So, for instance, someone who is interested in targeting the lateral commissure with whatever device might want to puncture inferiorly in order to get a nice trajectory towards the lateral commissure. On the other hand, someone who would want to do a paravalvular leak closure of the mitral valve on its medial side would want to stay away from an inferior puncture because you'd have to make a tight bend around and get into that medial pocket. In this case, we'd like to do a superior puncture as high as possible in order to appreciate or get into the medial commissure. So again, what you see there is an SVC puncture, and what you see there is an IVC puncture. Now, interestingly, there's a relationship between this atrial septum and mitral valve. What you see here are images taken from various patients where we've mapped out the atrial septum in yellow and the mitral valve in green, with the lateral and medial commissures highlighted with blue and red dots. And so there are instances where the atrial septum is found closer to the medial commissure, and in others where the atrial septum moves closer to the lateral commissure. And so sometimes it's important to understand this, because when we perform these complex procedures, sometimes we need to be extremely accurate if we want to be successful. And so it may be the case where in some patients, it really doesn't matter where you puncture in the atrial septum, because the relationship dictates that you'll get to your target of interest no matter what. In other cases, it might have a profound effect because you need to puncture at a particular location in order to get to your target of interest. Now, if we look at the short axis view of the heart, this is the other view that we use to puncture. What we maybe don't appreciate on echocardiography is that the mitral valve is somewhat in plane. And you see it here in light blue or in turquoise. And so if we appreciate that, then we can see that a posterior puncture, that is a puncture away from the aortic valve, is going to give us height from the mitral valve, whereas an anterior puncture, that is a puncture closer to the aortic valve, is going to give us less height from the mitral valve. And so it is the short axis view of the heart that allows us to appreciate whether or not we get height across the mitral valve. Again, this is in relation to our target structure of interest here, the mitral valve, where it was en face in the bicaval view and mostly in plane in the short axis view. So why don't we just go through a couple of case examples of how these chamber views and S-curves help in everyday clinical practice. So these are going to be just some little case examples. So for instance, here is a 3-chamber view of the heart where the aortic valve and mitral valve are both in plane. In fact, if they're both in plane, that means that it is a view where their S-curves intersect, the S-curves of the aortic valve and mitral valve. And you can see that in the bottom left-hand corner. There is one point where the blue and yellow curve intersect in ariocaudal. That ariocaudal gives us a 3-chamber view of the heart. Now, this is the chamber view in which you need to assess LVOT obstruction if you will be performing a transcatheter mitral valve replacement. And it's the only view that you can use to evaluate that. This was an interesting case we did several months ago, where we were planning to perform a sapien implantation into a failed surgical tricuspid valve prosthesis. And the patient had both tricuspid regurg and stenosis, and had a very large right atrium. And for some reason, our end-hole wedge catheter, as you see there, didn't want to go into the tricuspid valve and into the right ventricle. And so what we did was that we went into an ariocaudal view, which is a two-chamber view of the heart. And in a two-chamber view, again, if you understand the pattern recognition, you'll always appreciate that the coronary sinus comes out at almost 90 degrees with the tricuspid valve, albeit pointing downwards, as you see there highlighted in white writing. And so this end-hole wedge catheter kept on going into this huge coronary sinus. And so what we've done here now is we've superimposed the pre-procedural CT scan onto the fluoroscopic screen. And of course, we did this post-procedure. But, although we weren't fusing the images on the screen, we were fusing these images in our mind. And so what we have to do in this case, as you can imagine, is we need to pull on the end-hole wedge catheter, bring it more superior, get it away from the coronary sinus, and perhaps give that wire a little bit more of a bend in order to get across the tricuspid valve. Now, these are things that increase your procedural time sometimes by 5, 10, 15 minutes, especially when anatomies get tough. If you ever want to do a transseptal procedure, a transseptal mitral valve replacement, for instance, what I like to use is a 4-chamber view of the heart. That's found in an iliocranial view. And the reason for that is because in this view, both the atrial septum and the mitral valve are both in plane. And that gives you a nice trajectory of the angulation that your catheter has to take in order to get across the mitral valve. It's also the Valentine picture of the heart, and it's easy to understand the catheter going from right atrium to left atrium down across the mitral valve. Now, there's something interesting happening all the time, and I hope you realize, is that as interventionalists, as proceduralists doing these procedures, we always like to see structures either in plane or en face. And we always want our catheters to be coaxial or in plane with our target structure. And this is why understanding S-curves and understanding chamber views is very helpful. This is a clinical case example of someone, 75-year-old female who underwent Mitroclip implantation. She had severe functional ischemic MR with severe LV dysfunction, previous bypass surgery. You can see the baseline severe MR here. And let's take a look at the mitral before we get into the what we did with the Mitroclip. Let's just review chamber views and mitral valve leaflet segments. Again, there's a pattern recognition that we can develop with respect to chamber views and mitral valve leaflet segmentation. And so here you have the segments of the mitral valve highlighted. And if you are the blue eye appreciating the mitral valve from its caudal aspect, you can see it's coming from below, and it's coming from the left side of the screen, so that means right. We're in an ariocaudal view. You get a 3-chamber view of the heart, as you see there. And this blue eye would appreciate a separation of the anterior and posterior mitral valve leaflets on fluoroscopy. And so if you look all the way to the right-hand side on that fluoroscopic screen, in ariocaudal 3-chamber view, you can separate nicely the aorta, the anterior from posterior leaflet, but you'll have an overlap of A1, A2, and A3, and P1, P2, and P3. On the other hand, if you're looking from a cranial perspective from above, again from the right side of the patient, you'll generate, as we've seen before, a 2-chamber view of the heart in an ariocranial view. And if you are this red eye now, you have an overlap of the anterior and posterior mitral valve leaflets, but you can appreciate the A1P1, A2P2, and A3P3 segments separated from each other. And you see that on, again, the complete bottom right-hand side of the screen. That fluoroscopic image demonstrates to you that the A3P3, A2P2, and A1P1 segments can be separated, but you have an overlap of the anterior and posterior mitral valve leaflets on fluoroscopy. Now, this may seem a little bit non-traditional, but whenever possible, we get CT scans even in patients undergoing Mitroclip implantation. And so the way we use CT scans is that we generate the 3-chamber view and the perfect 2-chamber view of the heart. And of course, we try to respect the position of the clip, depending on which segments we're going to be clipping. And so in a 3-chamber view, we separate the anterior from posterior leaflet, and you'd expect the clip to have this orientation. And the 2-chamber view, being a 90-degree away from the 3-chamber view, you'd have the clip and profile. And so on the left-hand side here, you have the 3-chamber view of the heart with the clip ready to grasp. And that exact same 3-chamber view on the right-hand side can be seen on fluoroscopy with the clip widely open. That fluoroscopic view here was RAO 44, caudal 36. You can position your clip widely open in order to orient it in the right direction. Now, as we moved on with the procedure, we needed to put 2 clips. And what you see on the left-hand side is the 3-chamber view of the heart in ariocaudal. Now, there are actually 2 clips overlapping each other. The reason why it looks as if there's only 1 clip is because we have the perfect 3-chamber view with the clips completely overlapped. If we would move over to the 2-chamber view, you appreciate that the clips are side by side. We find that CT scan, when used correctly, can provide you the perfect 3-chamber, the perfect 2-chamber view. And it's been incredible to see how quick and accurate we can flip the orientation of the clip on our fluoroscopic screen. Of course, the grasping is done by echo, but there's an element of speed whereby the device is seen very nicely on fluoroscopy. Our devices are not always seen very nice on echo. Although we do see the chamber views nicely on echo, we don't see them very nicely on fluoro. And this is how we try to relate the 2 imaging modalities. And so once you have the perfect 3-chamber view, not only can you orient clips in the right direction, especially when you are implanting a second clip, you can put the second clip right next to the first clip in perfect orientation as well. And so that was the final result of that. And so, again, what we were hoping to do today is to share how chamber views can be used as a common language among the various heart team members, and that chamber views can be seen across imaging modalities. Secondly, we've went over the S-curves and we saw how S-curves can be related to chamber views. And finally, we went over a few clinical case examples involving the aortic mitral and tricuspid valve and saw how the use of chamber views and S-curves can help you elegantly navigate your catheters across the heart.
Well, thank you, Nico. I've had the pleasure of hearing this presentation before, and every time I hear it, I learn something new. It's a tremendous presentation. The only thing I missed by not seeing it live is I missed you using your iPhone in your shoes to explain how this works, which is really very helpful. So everything I do in open surgery is pattern recognition too, and I learned it by doing surgery over and over and over again. Is there a way to simulate this for people that are really wanting to do this, other than going into the cath lab every single day and thinking through each individual case? How did you go about learning this? Did you have a way of simulating this and then walking yourself through this?
Yeah, you know, Michael, it all started back when I was in Rotterdam. Carl Schultz, who was a dedicated CT fellow with us, started to implement CT in transcatheter aortic valve interventions. And I carried that knowledge over to Munich. And Munich at that time was performing almost 300 TAVIs per year. And so I was able to analyze hundreds and hundreds of CT scans during those early years. And, you know, the only way to do this, Michael, is really to analyze the CT scans for yourself. You have to experiment with the CT scan. You have to play with the CT scan. And there's no way around it. You know, we were talking about music before this, Michael, before we started. It's the same thing like playing a musical instrument. The only way to master it is to play it. And so I would urge all those people involved in these procedures to routinely download the CT scan and do your own analyses. And of course, you know, there's a feeling of apprehension and maybe feeling uncomfortable at the beginning. But I would say that after you do this about 15 to 20 times, or 30 times maybe, you start to get comfortable. You know, we train our fellows in Montreal to become imaging experts, first and foremost. And it's amazing to see their progression over a course of 1 or 2 months. You know, they become real, you know, it becomes really easy for them to analyze these CT scans. So again, Michael, you got to just do it yourself.
So we have 3 advanced structural fellows here, Nico, and we won't let them do a procedure unless they can do the imaging and show us they can do the imaging. It's somewhat worrisome that the commercial devices have people that will do the imaging for you, and they do a very good job. I somewhat worry that sites are dependent on this and not necessarily doing their own. I mean, what do you do? What's the kind of common theme in Canada? Do most of the interventionalists up there do their own, or are many of them counting on industry to hand them a 3-mensio report and say, here's what you should do?
Yeah, you know, Michael, Canada is a rather, although we're big in territory, we're rather small. And over the last 10 years, we've had numerous conferences where we've brought in all of the implanting centers across Canada, and we've had seminars and so on. I think for the most part, Canadian interventionalists analyze the CT scans for themselves. You've said something interesting, and I think is problematic. I think companies or strategic should somehow share the experience of analyzing the CT scan with the implanting physician, because it's amazing what you could learn from the CT scan. It makes no sense that these companies are analyzing these CTs and then send you back a PDF report. And perhaps you not appreciating that there was a bulky calcification on one cusp, or maybe that the atrial septum appeared thickened on the CT scan, and that might change your approach somehow. So again, I would urge everyone performing these procedures to download the CT scan yourself and analyze it.
So Nico, I have a question for you from Steve Little. I think you know Steve. He's one of my premier imagers here that I've learned a lot from. And Steve wants to know, do you get a CT for every Mitroclip case? And if not, which subset benefit the most from this extra data set?
Yeah, we don't get a CT scan for every Mitroclip case. We only get in patients who have normal renal function to begin with. If there's any form of renal dysfunction, we shy away. And you know, I didn't show you a clinical case example, but it works exceptionally well for the tricuspid valve. It takes away the uncertainties of understanding the echocardiographic anatomy while navigating a catheter, and brings that onto something more traditional like the fluoroscopic screen. You know, Michael, we had about 6-7 months ago, we had a patient who had congenitally corrected transposition of the great arteries and had a leaky left-sided valve, which was trileaflet. And so it was a little bit difficult to understand how we were going to approach this through echo. But knowing the orientation of the clip, and which leaflets we had to grasp, we put that information onto the CT scan. We got the view in which the clip should have been maximally opened or in profile. And that helped us quite a bit in trying to grasp leaflets and getting that clip quickly oriented. And so I would say that, whenever we see a complicated case, whenever we have normal renal function, we try to get a CT scan in our clip cases.
So let me ask you one last question since we're getting close to the end, Nico. We talked a lot about echo, fluoro, and CT. Where does cardiac MR fit into all this?
Yeah, I think that's the next frontier, Mike. We haven't, in clinical practice, whether, while we perform these structural heart interventions, we don't typically bring in the MRI into clinical practice. I think as we move on, it might have a tremendous role for understanding those who may or may not respond to our therapies. As we know, MRI provides great functional information. But again, it is limited. It's limited in the fact that it does not necessarily provide you with a 3D volume data set. The cuts you get on MRI, of course, you can scan in and out of a particular chamber view, but you do not have a 3D volume data set whereby you may use multiplanar reconstruction and understand the nuances of the heart. So I think MRI is going to have more of a functional role to play than providing structural information. I think that's going to be left to the CT scan.
Well, Nico, I want to thank you for an outstanding talk. I've always considered you the ideal image of an interventionalist. I learned so much from you every single time. And we and Houston and everybody listening in today appreciate the time and effort you've put into teaching us how to understand this imaging. So thank you. Stay safe and healthy up in Montreal.
Thank you. Same to you.